would say, the substances were not the problem, right? They were the solution to the problem. And our goal through providing treatment for patients is to really dig down and find out what that underlying problem was. For instance, if someone with pneumonia, we don't treat them with ibuprofen, because if we treat them with ibuprofen, we're managing the fever, which is the symptom of the disease, but we have to really treat them the underlying.
Hello, and welcome to 20-Minute Health Talk. I'm your host, Sandra Lindsay. Today we're taking a closer look at a critical and timely topic, addiction and the journey to recovery. We're honored to be joined by two distinguished guests, Andrew Drazen, visionary original founder of Wellbridge, Long Island's premier addiction treatment and rehabilitation center, and Dr. Edmund Akemi, medical director at Wellbridge. Dr. Akemi is a dual board-certified physician in internal medicine and addiction medicine. He also serves as faculty in the Department of Psychiatry at Brigham and Women's Hospital and instructor in psychiatry at Harvard Medical School. Welcome to you both. It's a privilege to have you here with me today. So let's start at the beginning, Andrew. Wellbridge has rapidly established itself as a beacon of hope for so many. How does a businessman get into addiction medicine, addiction services?
Well, the story for Wellbridge for me, my journey started actually 14 years ago tomorrow. I was growing up with two brothers, all under 10 years old, in Rockville Center, growing up in a broken home. My parents were divorced. My mother became very depressed and stopped eating, and she was taken to doctors who in those days prescribed amphetamines to get the kids off to school in the morning, barbiturates later in the day to get them to go to bed at night. And when I would come off the school bus at 3 o'clock in the afternoon, I would find her passed out on the living room floor with a bottle of vodka. In June of 1966, I was 9 years old, and she died of an overdose.
I'm so sorry.
Yes, it was tragic. And I was raised by my dad and his parents, my grandparents. But from all that tragedy and trauma and stigma and shame, I moved away from thinking about this for decades. Many, many decades passed. Got married very young, had children very young. I kept myself very busy. I couldn't look back. And then things happened later in my life that returned me to things that focused on addiction. And I started my journey. Like I said, it'll be 14 years ago when I sat with my partners to discuss Wellbridge. And that started our journey with getting it built and established and get going.
Well, thank you so much. I'm sorry to hear about your past, but that you turned that pain into purpose. And you said some words, trauma, stigma, and shame are usually what people feel when you talk about substance use and addiction.
Well, you also have to go way back to the 60s and the 70s where there was no understanding of behavioral health, of alcohol use disorder, of substance use disorder. We've come a long way, but we have a long way to go. So that's why I got involved with this.
So beyond your personal experience, did you see an unmet need on Long Island?
I did. I started to research and get educated on my own regarding addiction. I started running around Long Island with a notepad and sketches, and started to meet with nurses, doctors who I knew, who knew somebody else. And everybody said, if this could be built on Long Island, it would be one of a kind. The vision was always to build a place that was dignified and respectful and uplifting from the front door to the back. People who suffer with substance use disorder are traumatized, stigmatized, beaten down. And I wanted to build a facility that was lifting you up and treated you as a person. And that was the goal. And that was something that was going to be very unique, not only on Long Island, but probably in the country. So that's why we did it.
And having been there, and thank you so much for hosting me there, that's exactly how I feel. From the minute I drove in onto the property, I just felt the love and belonging and respect and dignity that you offered. Dr. Hakimi, can you comment on the unique nature of addiction as you see it on Long Island?
Absolutely. So, using the word unique, I want to touch on that because addiction is a universal disease. And although there are areas and pockets that are affected more based on historic exposure, being underserved and diverse, it affects everybody. There's nobody that's not affected by it. It doesn't recognize the education level, the wealth status, how much money people we have in the bank, their gender, their history. Everyone is susceptible to it. Mm-hmm. However, Long Island is different because it has these pockets of affluence where people might look from outside in and see families that have everything, but they suffer in silence. And then it has pockets that are very underserved and don't have the means to get access to treatment, and they get excluded from a lot of the good treatment. And I am a person in long-term recovery myself, and through my own journey, and through, on the other end, being a physician, helping other people through their journey, I noticed that the problem is not so much access to beds, it was the care that was provided through those beds. And that was always the mission, like Andy was talking about, building a place where not only is welcoming and it looks dignified, but also the care that people need to get is all under one roof. What we see with people right now with substance use disorder, they're very ill, right? Due to the contaminants and the drug supply. And people that get exposed to these kind of substances, they generally, by the time they get treatment, they haven't seen a provider for a long time, they haven't had access to treatment, they don't have a primary care, right? So none of the underlying medical or psychiatric comorbidities have been addressed. So by the time they come to treatment, it's not just a substance use, it's a multitude of co-occurring medical and psychiatric issues that need to be addressed. And the way this system has been structured for many different ways is people with complex medical issues or psychiatric issues, they need to get those addressed on a hospital level of care because most community-based treatment centers, they don't have the medical infrastructure to address those issues. And then there are great community-based treatment centers who have excellent clinical care, but they don't have that medical piece. So people either get to go to a hospital, get great medical care, and not optimal clinical care, or they need to go to a treatment center where they get great clinical care, but not medical care. And there's a lot of people that need access to treatment that fall in between this gray area. And one of the visions for Wellbridge, it was to implement a medical model that brings all of that together. And that was in the spirit of improving access for treatment, reducing stigma for patients with co-occurring disorders. And we know that a lot of these patients, if we don't address these underlying psychiatric and medical issues, we are not optimizing the chance at long-term recovery.
Thank you. So, Andrew, was that in your vision when you created the core philosophy and the founding principles at Wellbridge?
For sure. I mean, going back to my childhood and the lack of care that we had from my mom, the thought was always to provide a facility that would, present that care and offer it in a very deep way. As Edmund alluded to, addiction does not discriminate. It is from Park Avenue to Park Bench and everything in between. And so as beautiful as the facility was laid out and built on 96 acres, the care that we provide to each patient individually is what is perfectly married to the build of the facility. And to think that you can receive this care, this type of individual care, specialized care, medical attention, and have it all, or most of it all, covered by your insurance plan. It's really remarkable. And patients recognize that every day. So many treat every day as a gift, because typically in the past, you'd have to go somewhere and pay for this type of care with a credit card. But we have in-network contracts with all the commercial payers, and that's something I wanted to do from the outset, and we succeeded in doing that. So that's the reason. It all works together for the benefit of the patient, and that's what the goal was.
You also mentioned, and Dr. Hakimi, probably you can comment on this, how the care is individualized, it's holistic. I've been to your art therapy room, the spa, the chapel, and all these different services that you provide.
Absolutely. So in the spirit of what we're talking about improving access to treatment and bringing all the access for treatment under the same umbrella, is we have to manage all those medical, psychiatric, and substance use disorder at the same time. Now, we also don't want to just treat everything with medicines, right? And a lot of the underlying issues and underlying diagnoses that led to the substance use, there's a multitude of different ways that we can address it. So I always say, the substances were not the problem, right? They were the solution to the problem. And our goal through providing treatment for patients is to really dig down and find out what that underlying problem was. For instance, if someone with pneumonia, we don't treat them with ibuprofen, because if we treat them with ibuprofen, we're managing the fever, which is the symptom of a disease, but we have to really treat them the underlying with, let's say, antibiotics, right? So if somebody, let's say, has anxiety, that they originally start self-medicating with substances to be able to manage their life, we have to manage that anxiety and not just a substance use. And there is a lot of growing literature that points to the fact that there are other aspects that we can manage this anxiety other than just med management. Of course, med management have their own place in managing this, but we have seen multiple different studies that they look at, for example, exercise. It plays a very important role in managing anxiety for patients. And Andy has, in a part of building WellBridge, is a beautiful, huge wellness aspect to it, right? That patients love and enjoy using, but at the same time, it's evidence-based because we know that exercise can be as effective as, let's say, an SSRI for managing anxiety. So they have access to that, right? The beauty of a place, the way we treat the patients with respect and compassion, that also brings down some of those barriers for them, right? They're able to now open up and expose these traumas that they've been hiding for such a long time.
So, may I just add, so many patients come in, and when they go through Edmund's medical detox or stabilization program, they're losing their best friend, which is their drug. And so the idea from the outset, from years ago, planning it out with my partners, was to build a truly holistic campus with other venues, music, art, fitness, wellness. We have a golf simulator, we have 2 pools, to engage the brain into activities that were away from the drug. And it's remarkable what we see. We do see some patients that want to go to the gym 5 times a day. So it's a transferring. But most of the time, the art therapy, the music, the creative arts, we have a kiln for ceramics, the fitness center. It's remarkable that they feel that they are now filling that void with something else. And that was always the goal, and it works.
To that point, though, it's important when we're trying to help patients build that coping skills for when they leave, because our goal at WellBridge is to give them a sample of daily life, right? So what does recovery look like for you on a daily basis? And incorporating some of these healthy activities and healthy coping skills to either bring extra pleasure to life or manage some of the underlying stuff that they were running from. It provides them that, one, the options. So, you know what, I really like art. That really does calm me down. You know, I never thought about exercising. Now exercise, it does help me. So, and we know that we can replace something with nothing, right? So the goal is that we have them access to all these activities which are all evidence-based, by the way.
Yeah, and
so
I like
they can
that
take
you're
a piece of
using
that with them.
evidence. Yeah, healthy alternatives.
Healthy alternative.
We try to provide the tools to the patient so that when they leave us and they leave our very safe surroundings, that they'll have the tools in their toolbox to succeed in the real world. That's the goal.
That's great. But we know that just from our, conversation here in this short time, it's a complex, addiction is complex.
Yes.
So Dr. Hakimi, help us to fundamentally understand addiction.
Yes. How much time do we have?
I know we don't have enough time, but is it
But I'm
a
happy to,
failing? Is it a
Yes.
disease or
Yes.
something even more complex?
Yes, absolutely.
What does the science tell us?
Absolutely. So, historically, like Andy was alluding to at the beginning, we were treating addiction as a moral failing. However, we know now through decades of neuroscience that it is a chronic relapsing brain disease. And it's multifactorial, right? So it's biology and environment at the same time, right? Nature versus nurture. And we know that more than 50% of addiction is genetic. We know specific genes that attribute to addiction. We know that people with history of addiction in the family are more susceptible. But at the same time, it's the exposure and life experiences that attribute to whether or not a person develops a substance use disorder. For instance, if somebody has a very strong genetics, never ever uses a substance, there's no chance of developing substance use disorder, right? However, genetics make the brain of the person more susceptible to the fact that if they use that substance, they are more readily become dependent on it. Because the exposure to the substance, it can cause structural changes in the brain. So it does multiple things. So one is it affects the pathways that we have in the brain in a way that it produces a lot of dopamine, and dopamine, evolutionary-wise, we know that it encourages repeated activity, right? We see that for food, we see that for reproduction, we see that for housing, right? These are the stuff that increases our dopamine level. Substances tap into this, but in very magnified way. So the body thinks that this is part of that survival, so it taps into it, and then it becomes a relationship like Andy was talking about. But at the same time, it can change the brain in a way, let's say the prefrontal cortex, the front of the brain, it shrinks, and that's our executive part, right? That's the part that says, hey, don't drink anymore because you have work tomorrow. Is that break, right? Or you've overdosed twice already, maybe you shouldn't be using opioids anymore. That part of the brain shrinks. There's also really good twin studies that they've done where they looked at where, certain twins, they get adopted into two different families, they get adopted into a family who has substance use, that it doesn't have substance use. The chance of them developing a substance use with the same genetic in a different environment, it definitely affects how they get exposed and they develop substance use. So it's really this nature-nurture interplay, right? That is really important when you're understanding and listening to the patients about their story.
Interesting. So given this understanding, what are the most common psychiatric co-occurring disorders you observe in individuals struggling with substance use, and why is it so critical to address these alongside addiction itself?
Excellent. So addiction doesn't live in isolation. And, it's always, I talk about it, it's always like finding which one came first, chicken or the egg, right? There's by the time the patients get to us, they're in a more severe form of their disease. And they have some co-occurring mental health issues. Most commonly is major depressive disorder, general anxiety disorder, social anxiety, bipolar disorder. And it could even be some personality disorders, right? Like borderline personality disorder, histrionic personality disorder. And it can be that they had that underlying psychiatric diagnosis and they use the substances to cope with it, right? So if somebody has social anxiety, they turn into, let's say, sedatives or alcohol to help them engage, right? As the social lubricant. Or they were exposed to substances for a variety of reasons, and the substances induce some sort of underlying mood disorder. However, we know for a fact now through a lot of research that we have to address both at the same time right from the onset. We used to look at it as we have to treat the substance use first, wait some period of time to be able to diagnose the underlying mental health disorder, and then treat it. However, if someone's anxiety is so severe that they had to use substances to deal with life, now we say live without anything, they're just not able to. So we have to make sure that we address both at the same time.
Thank you so much. Well, that provides such a crucial foundation for understanding addiction and Wellbridge's commitment. In our next segment, we'll move beyond the why and into the how, exploring the comprehensive day-to-day experience of healing and recovery at Wellbridge. As always, thank you to our listeners for listening, and please join us for part 2 of this very important conversation next time on 20 Minute Health Talk. Until then, be well.